If everybody could please take a seat, make yourself comfortable. Welcome. My name is Michelle Arnaud. I'm the Vice President of Gray Panthers NYC. Welcome to the August 29th, 2023 edition of the Gray Panthers NYC Transformation Tuesdays. Today's webinar is entitled Building Bridges with the Industry. This presentation is the fourth and final of our Unity series, which is intended to bring advocates, residents, and industry leaders together. Every webinar is recorded and available on our website and on our YouTube channel, and you'll receive it after this is finished. Next month, we will introduce the Above and Beyond series, when we will award and feature outstanding staff members from across the country who work in long-term care and remained as the backbone of long-term care facilities during the pandemic. And now it's my pleasure to pass the mic to my co-chair, Carrie Liljadal. Carrie.
Hi, everyone. Thank you for joining us today. I'd like to introduce you to Beverly Laubert. She is the National Ombudsman Program Coordinator with the Administration for Community Living. And she's going to open us today with a few comments, and then we will get to our speakers. Beverly.
Hi, everyone. Thanks so much for inviting ACL to participate in the event today. I've often joined your webinars, and I'm always impressed with the thoughtful and thought-provoking discussions, and I anticipate that today will be no different. I've spent all my career advocating for people who receive long-term services and supports. 33 years of that as a long-term care ombudsman, and now at ACL, I get to work with ombudsmen across the country as they advocate for residents. Today's theme of building bridges is important, and I suspect not at all foreign to you. Always focused on resident needs, rights, and preferences, we collectively need many bridges. When individual residents have problems, there has to be a strong bridge with the staff in the home to resolve those problems. Sometimes it's necessary to involve regulators, and that's another bridge. The country is waiting with great anticipation for CMS to release a proposed staffing regulation. Such regulations aren't developed in a vacuum. They're developed based on what CMS knows and others know through research and daily interaction with residents, resident advocates, providers, and state regulators. More bridges. To make change in the systems of delivering care and services to residents, there have to be bridges with policymakers at every level, and I know that you've had some of them on these calls as well. Through your Transformation Tuesday events, there have been many good ideas discussed, and the list will likely grow today. The path to getting from idea to implementation must be paved with commitment and common understanding. And that's not always easy, but the diversity of voices is critical in building bridges that will have the strength to last through challenges like disagreement on what quality looks like, the optimal size of a care facility, how care is financed, and how many staff are needed to provide that care. As we listen to the presenters today, I hope the focus will be on a shared goal of enhancing the lives of residents, ensuring health and safety, and providing the highest quality of life and quality of care possible. By leveraging the collective wisdom and resources of advocates, families, government, and nursing home owners, operators, and staff, we should be able to make a positive impact. I know none of you are shy, and that your experiences, insights, and questions will enrich the discussion, enable us to delve deeper into this important work today. I, for one, am embracing this opportunity to learn from one another, hear about best practices, and foster a culture that will positively affect the lives of long-term care residents, because we must always have our focus on the residents. Thank you.
Thank you so much, Beverly. Now I will introduce our three presenters. I think everybody knows who they are, but I'll just briefly tell you about their background. So we will begin with Dr. Shari Ling. Dr. Ling serves as Deputy Chief Medical Officer for the Centers for Medicare and Medicaid Services. Her focus is on the achievement of meaningful health outcomes for patients and families through the delivery of high-quality, person-centered care across all care settings. Her clinical focus and scientific interest is in the care of persons with dementia, multiple chronic conditions, and functional limitations. She leads the CMS Behavioral Health Strategy implementation and represents CMS on several health and human services efforts. Our second speaker today will be Mark Parkinson. Mark Parkinson is the president and CEO of the American Healthcare Association, which represents over 14,000 skilled nursing facilities and assisted living centers. He served as the 45th governor of the state of Kansas. Prior to his election, he was the owner and operator of long-term care facilities in Kansas and Missouri. Under Parkinson's leadership, AHCA focuses on delivering policy solutions to the Hill and CMS with a special emphasis on quality care. Our final speaker today will be Susan Ryan, CEO of the Center for Innovation, the nonprofit parent of the Greenhouse Project and Pioneer Network. She leads the organization in its mission to fundamentally transform elder care. Since joining the Greenhouse team in 2008, Susan has become an internationally recognized leader in long-term care reform with a focus on the organization's vision for small home elder care campuses that provide person-directed alternatives to traditional nursing homes. And now I'll pass the mic over to Dr. Ling. Thank you.
Good day, all. Just checking sound, or someone give me thumbs up. Okay, terrific. Thank you so much, and really deeply appreciate the opportunity to spend some time with you all today. As was said earlier, not only do I have the opportunity to support CMS in its multiple actions to drive our system towards better health outcomes for all individuals who we serve, but I remain a committed geriatrician and gerontologist. So sincerely, I really appreciate the opportunity to engage in this conversation. I think the series and today really is importantly and appropriately named, which is, you know, to come together and build bridges, but having a shared mission and true north in mind, which is how do we together get to a better future, which is all of our futures, right? As we look ahead to shape a long-term care system that has the opportunity to meet the needs of those we serve. We have really also received from the event organizers a few questions. So, you know, being able to frame my remarks around these questions, I think will get us started. And one of the questions is how do we enable residents, families, advocates to ensure that their voices are being heard and have a more prominent seat at the table? And I will respond in the following way. I view this question as having multiple levels of a response. So as individuals representing those who are living in and receiving care and services, there are opportunities to engage with the local leadership and care team of any individual facilities. And that is the purpose of some of the information that CMS releases in the compare sites as a conversation starter. This is what we know of what quality and safety look like for individual facilities, but that is a starting place. This is meant to be a conversation starter between facilities and also those who receive care and services. Another is really to, and we're very supportive of this, enabling families and care recipients to get to know the leadership in facilities who are serving facilities, as well as the care teams, and certainly seeking out and building relationships with the assigned ombudsman and other facility staff. So these are opportunities at the individual level. In addition, though, important conversations can be had at the regional or locality level to ask questions and get the answers that are needed to really improve health, safety, and care that is provided. And finally, at a national and also regional level, CMS builds in opportunities by way of stakeholder engagement, in addition to public comments during the course of our quality measurement proposals and value-based purchasing proposals, all during the course of rulemaking, and even prior to that, to be able to engage and hear the voice of the people who we serve. I will say that prior to building this opportunity into our processes, the product that had been proposed looked very different from that which had been refined based on stakeholders like you, like families and caregivers, and people who really care about the outcomes and the care level that is provided at individual facilities. So although at a national level, I believe there still is opportunity, and we intend to build that into our policy work moving forward. I will also add, though, in response to a question about, the need for clarity around the enforcement of minimum health and safety standards, concerns of the rigor of the survey system. We're very open to receiving any feedback that you may have about the survey process, the opportunities to use the data to improve care and outcomes, but also, to drive towards a better experience of care, right? That those who visit and provide care for nursing home residents, and as well as those who reside and receive care and services in facilities, I believe that there is opportunity to improve. We are all in the improvement business. It is part of our obligation to improve not only how care is delivered, improving on raising the floor of minimum health and safety standards, but also how our processes roll. Now, there was a question in the chat. I don't know if I'm supposed to answer that quite yet, but I think it's relevant. Many of you are interested, and Bev actually mentioned the minimum health and safety standards, the actual minimum staffing standards. I will say stay tuned. We have committed to making this the standards publicly known in the summer, and we are still in summer, but stay tuned. This is forthcoming shortly. Now, I've also been asked, as far as recommendations for our elected officials, and also any opportunity to opine on forthcoming or proposed legislation. Unfortunately, I'm not in a position through my role to be able to opine on such matters. Having said that, I think there's tremendous opportunity for us at CMS, for our industry partners, and also for the public and advocacy partners to really be able to focus on what it means to truly be person-centered. To respond to a question of the focus on making such emphasis on home and community-based services, as well as on improving the minimum health and safety standards, I think this is all about a continuum of care that we would love to enable true choices for those who we serve. There will always be need and roles for care that is delivered in the context of healthcare facilities, and also in the community. So how do we get to a place where every individual who for whom care and services can result in better health outcomes, whether they're in the community or within facilities? How do we actually get to that sweet spot? So I wanted to end there by saying, I think that would be the general theme: building robust choice for those who we serve and providing the information that is needed to make those choices in advance, rather than as as due course of here are care processes and the choices determined for you. We want to make those choices real and support that robust decision making. So I'll stop there, and not sure who I turn it back to,
Well,
or
thank
if
you.
I turn it to Mark.
Sure, Mark is next. Thank you so much.
Well, thank you very much. And I want to echo the doctor's comments and thank all of you for hosting this event. I particularly want to thank the Gray Panthers for their work, and they're including me. And I think it's a fantastic idea to bring everybody together, and it's a privilege to be on the panel with two other panelists that are such high, they've done a lot. It's great to be on with both of them. The Greenhouse Project is something that's always fascinated me, and I'm anxious to hear Susan's comments. I'm thrilled that we're all together, because I think it's basically the only way you get stuff done. And I've been involved in business and public policy and taking care of folks, and I'm getting older, and I've got a lot of years behind me. And when you can pull people together and work towards a common goal, you got a much better chance to get things done than when you're just fighting with each other. When you're just fighting with each other, whether it's in DC or in a state capital or in a business or in a church or a community or a family, you can keep stuff from happening, but you can't get anything done. And unfortunately, too often in long-term care, we're all fighting with each other, so nothing's getting done. I think that the history of my involvement has been that when people pull together, try to figure out where are the areas that we could agree and what can we work on, that's when we can really move policy in a positive way. So the first thing I would say is that we know that when we work together, things can happen in a very positive sense. And I'll give some examples of that in just a second. The second thing I would say is that there is a common goal to improve quality, to provide great quality care in facilities. And I know that there are undoubtedly some people that are, on the call or in the meeting that don't think that the sector is committed to improving quality. And I would just ask you to not judge everybody in the sector by the bad actions of some providers. There is so much misinformation about the sector among people that aren't deeply involved in it. Our sector is very decentralized. And what I mean by that is that long ago, folks figured out that large companies couldn't do this. Large companies tried to do this. And back in the 1990s, there was a company that many of you have probably heard of called Beverly that got up to, over 1,000 buildings out of the 15,000 that are out there, and it just didn't work. Then, unfortunately, in the early 2000s, in the 2008 to 2010 timeframe, private equity got involved in the nursing home industry, and that didn't work. Private equity got involved, bought 4 or 5 of the larger companies, took some money out of the system, and that didn't work. But the misinformation about what we are now compared to what we were then continues it goes on, and unfortunately, it drives policy. We know, for example, that only 5% of the buildings out there, of the 15,000, are owned by private equity. And yet many people in the advocacy community continue to spend all of their time going after private equity. The private equity deals didn't work. That's a story of 15 years ago. So right now we have a sector that is very much ma and pa. And what I mean by that is it's people like Stacy and I, my wife and I, who we developed this dream to take care of older people. So we built one assisted living facility, and we thought that that's all that we would ever have. And we were perfectly content with that. We loved taking care of our families and our residents and their families, but it grew bigger. We ended up with 6 facilities, both assisted living buildings and nursing homes. And you might say, well, that's not how it normally is. It's normally these really big companies out there. Well, that's not the case. Half of the 15,000 buildings of nursing homes that are out there are in organizations that have 10 or fewer buildings. We call them independent owners. They're big businesses because each of these buildings is an enterprise in and of itself. But these are not these huge conglomerates that I think people tend to think of. Private equity was a bad thing. It's too bad that those transactions occurred in 2010, but that's a story of 15 years ago. What we face now is a continuing challenge. It is really, really hard to do this work. For 10 years, my wife and I had the privilege of owning our buildings and working in our buildings almost every day. I promise you we worked in them every weekend because we could never figure weekend staffing out. It's really hard. It's very challenging to take care of our residents. It's an honor, but it's really, really tough. And unfortunately, some negative things occur. But the overwhelming majority of folks that are in the sector are very committed to the mission that we have here at our organization, which is to improve quality. I know we can do it. There is still a lot of low-hanging fruit in the quality area, and that's what's so frustrating. It's frustrating to me that we're fighting with each other so often on areas that don't matter or that can never be accomplished because they're simply impossible when there's low-hanging fruit out there that can still be achieved. We know, for example, that when we work together with an administration, we can move the quality numbers. One of the best things that happened to me in my career is when I came to DC, Dr. Berwick was the head of CMS. He was very committed to improving quality in facilities. And we developed a joint goal of moving 3 clinical measures and coming together and doing that. And we were able to successfully do that. More recently, with Secretary Becerra and Administrator Brooks LaSure, they were very concerned, as they should have been, about the low vaccination rate, up-to-date vaccination rate in facilities. And we worked together and we were able to move those numbers. We can make things a lot better if we work together, but we really can't do it, in my opinion, if we continue to fight. So, my suggestion for effectiveness for all of us is if we could agree to some joint goals, the administration, the advocates, the industry, we can achieve these. And I would throw out as what I view as low-hanging fruit is, number one, let's go after the bad actors. Let's go after the poor performers. Right now, whether you're a great facility or a terrible facility, you get surveyed the same way, with the same frequency, and with the same resources. That doesn't make any sense to me. So often the penalties that are out there are applied both to good providers and good operators and poor operators. And I say, let's figure out who the poor operators are and get rid of them. The second thing is that we're going to have to put a real effort on staff retention. We can't find workers in our space, which is just one of the reasons why the minimum staffing rule will simply not work. We can't find workers, but collectively, we're going to have to work together to figure out a way to keep them. And that's, if we would set as a goal to work with facilities to improve staff retention, lower turnover rates, I really think we could do it. I am so thankful that you're bringing on great workers that have done a good job. That's the kind of recognition that people need to receive to continue to stay in the sector, and thank you for doing that. And finally, if there are clinical measures that we can agree on that need to be improved, we can do that. We have the attention of most of the facilities in the country. CMS has the bully pulpit. We can move the numbers. We can't improve quality by proposing things that can't be done, but we can absolutely improve quality by working together, figuring out what to focus on, and helping people achieve those goals. And again, I thank you for including me today, and I look forward to questions and answers.
Thank you so much. And our final speaker is Susan Ryan. So Susan.
Yes, thank you. Yeah, thank you so much, Michelle. And I just want to acknowledge Transformation Tuesday and for inviting me to have a seat at the transformation table. I'm really excited about your vision and what you are really seeking to do. And you reference the building bridges and, you know, finding that collective wisdom, Bev, that you talked about in your introductory remarks. That's where my heart beats. And that's why I'm so delighted to be here. I think, you know, what I would also say in that vein is that culture change or shifting the paradigm that we know of long-term care, nursing home reform, it can't happen in silos. We've got to find our commonalities, our common goals, and those things, Mark, that you were saying, what can we agree upon? And how can we really work together to really put those things in place? I'm going to make it personal. I was a very young director of nursing decades ago, decades ago. And I will tell you that when the survey process came, I was young enough, and one might call it naive, but I would just call it, I just had the good faith to believe that the surveyors and me, that we had the same thing at the core of our being, that we really wanted the same thing, and that was quality for those that live there, and even those that work there. We each wore different hats. So that's kind of the lens by which I came into this field. And we all have to acknowledge the lens by which we come into the field and the hat that we're currently wearing right now. The other thing that I will say to preface my introductory remarks, or the remarks that I will make, is the National Academies of Science, Engineering, and Medicine issued a 600-page report. And it was all about what we needed to do to really initiate improvement in quality in nursing home reform. And I'll just read one of those things. It says, honoring our commitment to residents, families, and staff. That's why we're all here, because we want to honor our commitment. We all wear a different hat, but that's what's at the core of each of us here. The other thing that I would add to it is the Moving Forward Coalition is a 2-year grant-funded coalition of diverse stakeholders. And I think that's the other thing that we're talking about. We need diversity of voices. It can't just be all the providers. It can't just be the regulatory bodies. It can't just be, you know, the provider organizations, but it's a multi-stakeholder coalition to really operationalize the goals of the National Academies report. If you haven't read it, there is a summary. You don't have to read all 600 pages, but I would go to the Moving Forward Coalition's website, and you can find the summary that really takes those 600 pages and really talks about the goals and the recommendations. I'm honored to be a co-chair along with colleagues Penny Cook and Tatiana Shippey from University of Minnesota. And we are all about advancing person-centered care, looking at the care plan process, and we're also looking at physical environments. That's only one of 7 goals. So when I reviewed the questions and really thought about what I would say to you here today, you know, obviously I'm really representing the idea that we've got to shift our culture. We've got to think differently. And it really is about our mindsets and our beliefs. And when we're talking about that first question that we were asked to answer, how can residents, their families, and advocates ensure their voices are being heard? And as I think about it, I think about, well, what are those critical success factors that we need to think about so that we can ensure that happens? And the first thing is really shifting beliefs, as I say. We've got to believe that those voices matter, that if we are engaged in the care planning process, if the resident is not a part of the care planning process, we've missed. a vital part of creating person-centered care. What's important to that person? And we all know that there's an inextricable link between families and their loved one. Families matter. And so it's important for us as well to be able to ensure that we have the systems and the structures to ensure that family voices are a part of it as well. So as I referenced the Moving Forward Coalition, Goal 1, we are really working to operationalize Goal 1 and really think about the care plan process and what we really need to do to ensure that care planning process is definitely inclusive of all those voices that need to be at the table. The other, couple other things from a system structures perspective, what does formal and informal communication look like? And how do we really ensure that the mechanisms, the systems and structures are there for communication to happen? Culture is all about deep trusting relationships. And it really happens in a context of consistent staffing. Yes, to adequate staffing, but it's really more about those consistent faces that are really developing relationships with family members as well as those that they are caring for. I'm not going to talk a lot about the survey system. I would encourage you to look at the National Academy's report. They have a lot of ideas. I just attended the Association of Health Facilities State Survey Agencies Conference in Nashville, Tennessee, a couple of weeks ago. Bev, I think you were there as well. And I can tell you that building, those stakeholder relationships with state survey agency directors and really talking and listening to hear what some of the challenges they're facing as well. How do we find our commonalities? So it's really showing up and having those conversations to determine how we move things forward. I will tell you that what do surveyors need to be successful? Do they have the capacity? Do they have the personnel? Do they have the education and the training to really understand the guidance that's a part of our regulatory standards and such? The question was asked, so what do you suggest as an alternative to fines? Well, I like to say incentives matter. And I would also say that you can't punish your way to success. So we've got to figure out what are the ways that we can take a look at reimbursement as an example. And what can we do to incentivize quality? What can we do to incentivize private rooms? If we know that private rooms made a difference in COVID, then why wouldn't we want to incentivize the development and the ability for nursing homes to get to that place where private rooms are more normative? I was early in my tenure at Greenhouse, and I remember hearing Kathy Greenlee, former Assistant Secretary for Aging under the Obama administration. And I'll never forget, I wrote it down immediately. She said, we need to incent what we want to see. And when I think about my work in culture change, I think about what can we do to really advocate for those incentives that are going to get us where we want to be. I would say there's never a one size singular approach, that there's really many things that need to be done. It's not just if we have the right minimum staffing standards that everything will be fixed. That's not the case. It's multifactorial. There are many things that we need to take a look at. And again, I would draw your attention to the NASEM goals because I think that's really important. So home and community-based services versus nursing homes. And I'm going to make it a bit personal once again. Also in my tenure as a nurse, I had the opportunity to work with a grant-funded initiative to prevent institutionalization of the elderly. And it was an initiative that kind of fell at a time where I had my call to action moment where I thought, nursing homes, this is not working. It's where restraints were best practices. And I thought, this isn't working. It was creating all sorts of untoward outcomes. And so when this opportunity came along, I said, yes, that's the answer. Let's just close those buildings and let's just devote all of our resources into creating home and community-based services. And this was way before HCBS was cool and what everybody was talking about. So what I can tell you, once again, there's not a one size that fits all. And I can tell you in my years of working both at the grant-funded initiative and other private home care agencies and Medicare certified agencies, I can tell you that as wonderful as HCBS is and essential as it is to develop that infrastructure, we must have dignified long-term care environments. And we've got to appropriate resources to both. It's not an either or, it's a both and. And we've got to really think about that ecosystem from acute care all the way into home and community-based. But nursing homes are a part, an essential part of that ecosystem. Our North Star for the Center for Innovation is person-directed living in the setting of one's choice. And that's implicit that those services and support are there to enable that person to do that. And there's a lot of infrastructure that really needs to happen. I would say if there's one thing that I could recommend to elected officials, well, I would say there's never one thing. And I'm not going to give you my one thing that would make a difference because I don't believe it's that simple. There's no silver bullet for this. And I would ask the big question, do we want to tweak or transform a system? And if the answer is we want to transform the system, then we've got to create a compelling vision, a vision that prioritizes people, a vision that says those that live there, those that work there are valuable to really getting to those solutions. And the other thing, going back to my beliefs, we've got to confront our biases. We've got to confront the fact that we're an ageist society, and there's ableism, there's racism, there are many, many isms out there, but we've got to address it because guess what? Our spending follows what we value in society. And so we've got to think about how we feel about those living in nursing homes. The other thing is Greenhouse has a frame in our education. We call it support and accountability. And I think that applies here. Support, what are the resources? What is reimbursement? What is financing? What is the education? What is the support necessary to really address the decades-old broken systems that we've been trying to, in my opinion, tweak for decades? What are we going to do to really provide the essential support to go where we want to go, to really hit that vision that we're talking about? And then what is the transparency? What's the accountability? What are the mechanisms that we will do? And Marcus, you were talking about private equity and to some of those bad actors. What are the metrics? What are we looking at? How do we hold folks accountable? If there is more funding, and I do believe it's underfunded, so there's more funding, but where's the funding going to? And how do we hold organizations accountable to using those funds in the appropriate way that prioritizes people? I will tell you, during COVID, I was fortunate to be a part of the AHRQ COVID Echo series, and we worked with nursing homes in the state of Maryland and nursing homes in the state of Arkansas. And what a privilege it was to receive the appropriation of those funds to be able to deliver guidance and best practice at a time when nursing homes needed it so drastically. When I think about, so why wouldn't we, why couldn't we appropriate some funding and use the ECHO platform to really get culture change out there, to really think about the systems and the leadership, the education, really getting it in the hands of people who need it most. I don't know how many of you understand that there in the Affordable Care Act, Section 6114, there is a national culture change demonstration pilot. I would love to see dollars appropriated so we could really determine how we go forward to really shift culture, really shift paradigms, really transform systems with the appropriation and infusion of those dollars to be able to do that. On the Pioneer Network website, you will find an Artifacts of Culture Change tool. It is free. It is gives you the opportunity to be able, as an organization, to assess your culture and say, well, where are we? And it's free, and it gives you that opportunity then to try to create your path forward. And finally, I guess the Moving Forward Coalition, we have just completed action plans at the end of year 1. And in year 2, we will be going out to mobilize those action plans. I would encourage you to take a look at that website so that you can learn more about what we are doing. And I guess the last thing, given the fact that I'm a decades-old nurse, I'd like to say, what legacy are we as leaders leaving to the generation that will follow us? what can we do to really help shape the future of long-term care? What can we do now so that when I started prior to OBRA 87, where have we come? What have we done? And, God forbid that, we don't leave it the same way as we found it. So it's my challenge to all of us and to the fearless advocates that are here. Thanks so much for the opportunity.
Thank you for everything to our three presenters. We have a lot of questions, so I'm going to just jump right into them. The first one is for all three of you. Are you in favor of a federal bill which will ensure 2 resident designated essential caregivers are allowed access, one at a time, to a federally funded long-term care facility during a public health emergency, while being required to be trained in and follow the same written safety protocols as staff? Who would like to answer?
I'd be happy to go first, or I'll defer.
Please.
Okay, yeah, this is a really fantastic effort that I know has been undertaken by some families, and I've had a chance to meet with some of the people that have really driven this effort, and we 100% support the idea. And just this is an example of where we need to work together and try to find good solutions for folks. So first of all, I want to thank the people that continue to push this both at the federal level and at the state level. But I also want to explain what happened at the federal level. What happened at the federal level is that we met with these people. We said, yeah, we absolutely support this. We'll work on giving folks the training. And if it takes extra time, that's okay. It's critical to have people in the buildings. And then the language was taken to an advocacy group, I don't know which one, who insisted that it includes some language that would create a deficiency if it wasn't followed in the right way. And if you run a nursing home, if you work in a nursing home, the last thing that we need is another deficiency that can be cited, another fine that can be issued. And so we said, look, we really want to support this thing, but it's very hard for us to support something that's going to create another deficiency or another citation. So our position is take that out, and open up the facilities to family members in these times of crisis, and we're 100% behind it. But again, it's just an example. If we could just trust each other a little bit more, work together a little bit more, we can get so much more done.
Okay, thank you. The next question, Dr. Ling, I think you already addressed it about CMS has not incorporated into the 2023 fiscal year plan the minimum staffing standards. I think you indicated that something is going to be.
We are working on it.
Yeah, okay.
Yes, but I did also want to, although I cannot opine on pending legislation, I do have a question about, Mark mentioned his support of the concept in times of public health emergencies. I will also ask the question, how about in times that are not quite as challenging? I am curious about that in a completely different field, tracking to, how they are other work on awake and walking intensive care units where families are coming in with what looks like really intriguing and promising outcomes. So it would be good to have data in how families are engaged in this way and the outcomes that can be delivered. So thanks so much. Sorry. Go back to your usual programming. Sorry.
So CNAs must be paid fairly for their work and need a raise. How can that happen? Who would like to take that question?
Well,
Any
I mean,
thoughts?
I certainly don't want to dominate, and I'd rather
Go
listen
ahead.
to Dr. Ling, but there are very few things that positive out of the pandemic. It's the worst experience in my lifetime, and for all of us, it's been horrific. But one thing that's happened is that CNA wages have gone way up, which is great. CNA wages are up 25 or 30%. I think we're getting to a point where we're getting close to a livable wage, but we've seen a dramatic jump, which is a good thing, over the last 3 years or so. And hopefully that trend will continue. So again, I don't know specific to the New York area, which is where I assume a number of you are from, but nationwide, we've seen a 25 or 30% increase. And, I think we're all very pleased about that. It's made it challenging on the business side, but the good news on that is that a number of state legislators are stepping up and helping with the Medicaid rates to deal with the wage increases that are necessary. Not all the states, and I know that New York has lagged behind, but I think it's been a real plus, and hopefully we're getting to a point where this can become a career and not just a 6-month, passing through type thing.
I would just add just a quick comment, and I'm going to channel Lori Porter, who I saw put a comment in the chat, who is the CEO for NACA. And, she says CNAs, certified nursing assistants, have solutions. And I believe that's right. And it's the power of listening to really what they need. And Mark, you were talking about career paths and career ladders and lattices and that sort of thing, opportunities to really grow as part of thinking about compensation. And the final thing that I would say quickly is the National Academies, that Moving Forward Coalition, in the action plan, they're talking about compensation and how to really address compensation. So there are some parameters and ways to think about it.
Thank you. Then also, Dr. Ling, there are questions about lessons learned by CMS during COVID. Someone is asking what CMS may have done wrong, and how flexibility was a dangerous element. And how can CMS control owners of private equity who may be bad actors? Is there a plan?
So this is a little tricky, right? Because we have to stay within what CMS authorities are. I think one of the authorities is to utilize the health and safety standards and quality, both of which are within CMS authorities. I think the other is, to be able to use data in ways that support not only delivering to the minimum health and safety standards, but going beyond. The question becomes, what additional data might be useful, and not just for CMS purposes, but the point of data is to make it actionable at the points of care. So whether or not, and this was also helpful and challenging during the public health emergency, right? Requiring data that and developing a data source that was useful for purposes of where are the holes, where are the gaps in the system. That was really critical. The challenge as far as flexibility is that there is no one panacea to all that we observed in the public health emergency. But now, as we're looking at where we are and applying what we have learned, including the fact that, boy, it would have been helpful to be able to identify and reach all those who needed to know quickly for purposes of, improving not only the infection control practices to mitigate spread, but also be able to impart those treatments and services that were necessary to keep people not only safe, but also engaged and improving their well-being. And I would, and this is not by any means a criticism or for the policies that were enacted, but just kind of fact of the matter is, I would love to see long-term care move back in the direction of being not only safe places to receive care and services, but to actually be returned to a time of being very person-centered and about feeling more like a home. So hopefully that addresses the questions in a way that makes sense. So thank you. Over.
Yeah, and let me just say, if you don't mind, I think the enormous policy mistake was that older people were not prioritized. Now, you can say that we didn't understand COVID and, so give the prior administration a pass, and that may be the case. But there were decisions that were made in the early days of the pandemic that sent all of the limited resources that we had to hospitals. And then we even created some floating hospitals. And you might recall that one of them came up to New York that was never utilized. So the very limited number of masks, and then when we got tests, which you might recall, it took a few months, the very limited number of tests did not come into facilities. So our members, providers, we were making our own masks. We were making our own gowns. We didn't have tests. The policymakers were requiring, for example, in New York, that you tested every 3 days. You couldn't even get a test result back for 10. The mistake that was made was that older people were not prioritized. Once we started prioritizing older people, which was with the vaccine, we started to see better results. And so this is an area where clearly we can all agree that older people in these crises need to be prioritized. It did not occur in the pandemic, and the results were tragic.
Well, that leads to the next question. What is being done at the federal level to protect seniors who live in assisted living facilities? Any answers? Well,
again, I'm happy to jump in.
Sure.
So obviously the nursing homes are regulated at the federal level and also at the state level. Historically, assisted living facilities have been regulated at the state level. As a result of the pandemic, there has been some discussion that there should be more involvement at the federal level, but to be, blunt about it, that discussion really has been muted by a lot of other issues. So I don't think, and perhaps we can hear from Dr. Ling. I don't think right now that's a front burner issue, at least not that I'm aware of.
Well, I'll move on since we have a lot more questions. Facilities don't typically introduce families to things like family councils, resident councils, the ombudsman. And without knowing about these systems, let's see, what systems are being put in place to communicate these systems to the residents? That's for Dr. Ling.
Oh, thank you. So let me just reframe the question so that I make sure I've got it. What is being done, what can be done to notify, inform families, residents of these opportunities? So it's a good question. And my question back to you is, what would be some effective ways of communicating these opportunities? Usually, CMS will communicate directly with facilities and either directly or indirectly with healthcare providers. But what would be an effective and useful way to really shed light on some of these opportunities that I think already exist, but perhaps are not, proactively offered? And probably don't have time to get some of that today, but perhaps, you know, when I would love to get a copy of these the chat when you're done as well. Would love to hear, so maybe folks can submit some ideas through the chat. That would be helpful. Thank you. Over.
I'm hoping that our Transformation Tuesdays is a means of helping the public to understand their entitlements. Again, Dr. Ling, there's a question about the Essential Caregivers Act as a means of securing greater health and safety for the loved ones in residential care. How will you help to get this act get passed?
So this is not something that we can do. We're on the receiving end of laws. CMS is an implementation agency. So I think the concepts, the principles are really quite aligned with person-centered care, but cannot make an official comment on pending legislation. So occasionally we are invited to provide some technical assistance, but until that happens, we're really not able to comment. Over.
Okay, thank you. Then Mark, a question for you. Does AHCA have a code of ethics for its members? And if so, what happens when the ethics are violated?
Yeah, we are not a policing agency. I mean, it's not really what we do. We do have a lot of data. We have the largest part of our organization is our quality division, where we lead the largest Malcolm Baldrige-based quality award program in the country, with literally thousands of buildings that have gone through it. And as part of that data collection, we do flag facilities that are being challenged, you know, that aren't doing great. And we have programs and efforts to try to get them better. But in terms of like monitoring, I'm not exactly sure on ethics exactly what it's a reference to. We don't have a group that does that.
And also, Mark, a question for you. Someone would like to know, as an advocate for essential caregivers legislation, what would be needed to receive your endorsement? Federal legislators and employers at United Health have asked about your endorsement.
Yeah, I mean, we were very excited to get on board, and we're really looking to push the legislation and put our full force behind it. But when the provisions were changed to add additional fines and citations, we just didn't feel like we could do it. So we're happy to do it in what we saw it as its original form. And so whoever's asking these questions, if you think that's possible, please get in contact with me and we'd love to get involved.
Thank you. Dr. Ling, you mentioned information that CMS puts out on nursing homes. Has there been a study to determine what information is most valuable? Someone believes there's a lot of information, but not easily accessible. So I guess.
Really, yeah, good question. We do look at the content, review and consider what should be refined, what's kept, what's jettisoned. It very much so aligns though with, you know, is quality topping out, or how we measure it for specific measures. And we are attempting to also align some of the measures and measurement across the care setting, so that consumers can make choices about not just within, you know, the nursing home setting, but how do you actually decide what setting is right for you. So have not really done a study per se, but always open to suggestions and ideas about how we would be able to display that which is meaningful and helpful across our care compare sites, and including for nursing home care. So thank you for the question. Over.
There's a lot of people are asking, what is Care Compare? This seems to be a new concept.
Oh, sorry. Yeah. So sorry. So yes. So this is if you think about comparisons of quality within nursing homes, take it up one level to address not just nursing homes, but also other post-acute care settings, and also, you know, across the care continuum. So it's meant to be a level up, if you will, with better alignment of content across care settings. Again, really the purpose is to be able to ask the question, you know, what setting is right for me? And to also understand the depth of what information is available. So apologize for using that term, but that is the purpose of Care Compare, quality across care settings. Over. Thank you.
Thank
Well,
you, Dr. Ling.
Go ahead. Ken.
It's 2:00. We know that a lot of our presenters have other meetings this afternoon. We will share all the questions with our presenters and everybody else. I can't promise that we can get all the questions online, but we will try to figure out if there's a way for us to do that. Presenters have all asked that we send them the questions, and we will do that for sure. I want to thank everyone, especially our guest speakers, for joining us today. Gray Panthers of New York is committed to helping create unity in the long-term community. And that's not just for New York, that's nationwide that we're doing this. Our audience today is comprised of a representative group of all of long-term care. We worked really hard to be as inclusive as possible into this one short hour. We hope that everyone that attended today will continue to work to improve the lives of all residents of long-term care. Here, you know, we have to work to keep these doors open for a better future, and we must work together.
Thank you, Carrie. And we look forward to seeing everybody on September 26th when we honor some very deserving long-term care staff. So thanks to everybody for participating in today's webinar. See you next month.
And before we leave, I'm going to make one comment. Let's do a shout out to Michelle and Carrie for putting together this fantastic, important Transformation Tuesday.